Very good afternoon again. This paper is titled Indications, Practice Pattern of Immune Modulation and Outcome of Repeat Optical Penetrating Keratoplasty. The purpose is basically to determine the indications and how the immune modulation is presently practiced and what are the outcomes. We particularly focused on optical penetrating keratoplasty for a variety of reasons, which I'll just share in the background. So we all understand that graft survival reduces as the number of repeat penetrating keratoplasties increase. But major studies in this regard are more than 2 decades old, and majority of them actually include therapeutic penetrating keratoplasties and lamellar grafts also. So thereby skewing the data. CCTS, which is from 1994, told us that the rejection rates increase approximately 1.2 folds with each extra graft. And Dr. Vanathy et al. In 2005 showed us that in regrafts in particular, the failure rate is close to 47.2%. A very recent study by Dr. Jodh Mehta from Singapore actually studied a PK regraft subset of patients, and this is what even we are focused on. These are 54 patients, and they studied only the first graft outcome, and with a very, very meager survival probability of 43.1. So this adds importance to our paper, and also in accordance with the immune modulation, which actually gains more importance in this particular subset of patients, with the majority of them being monocular patients, and for that reason they've undergone repeat grafts. So there is no consensus in terms of any immune modulation algorithm till now world over. This brings me to the need for this study, and with this objective, we studied patients who underwent repeat optical penetrating keratoplasty over a period of 5 years, and we analyzed the failure, rejection, as well as the factors which were responsible for them. We excluded patients who had undergone therapeutic or lamellar keratoplasty or those who were lost to follow-up. The primary outcome measures were graft survival, which was defined as clear graft at the last follow-up, graft failure, which is loss of clarity of graft at last follow-up, and the secondary outcome measures were time to graft failure and the improvement in vision. So we had 4,454 optical PKs which were performed in the study period in our network, out of which 259, which is 58.1%, were repeat optical PKs. Males were more as compared to females. Coming to the grafts and the indications, more than 4 failed OPKs were seen in 5% patients. And the primary OPK was primarily for a corneal scar, surprisingly a non-HSV scar, as against what is known that HSV corneal scars actually tend to recur and have more repeated keratoplasties. And last OPK was documented rejection was noted in the last OPK in more than 42% patients. So baseline risk factors which are already known, like more than 2 quadrant deep vessels, were seen in half of our patients, and more than 2 failed grafts were also in around 40% of them. The immune modulation practice pattern, despite these being very high-risk grafts, was preoperatively noted in 19% patients and post-op in 7%. The post-op topical steroids were tapered with a mean frequency of 10 times per day at 1 week, and then gradually by the end of 1 year, they were at almost 2 times per day. The primary outcome measure, which is the graft survival, can be seen here in the Kaplan-Meier chart. The clear grafts at the last follow-up were seen in 38.8% patients, and opaque or failed grafts were there in 61% patients. So 9 patients were lost to follow-up within 1 month, and this Kaplan-Meier chart covered basically 240 patients and 249 patients, while 259 is what we started with. And one did not have a proper failed event reported. For that reason, was excluded from Kaplan-Meier chart. The secondary outcome measure, which is the time to failure, is actually interesting and something translational which we can bring to our clinics. The median graft survival time was 36 months, and the survival rate of repeat optical PKs in females was lower than in males with an early failure. The secondary outcome measure, the best corrected visual acuity, it was seen to improve maximally at 1 month and then had a gradual decline, a very gradual decline after the 3-month follow-up. So we continued to do a univariate and a multivariate analysis. In the multivariate analysis, age, presence of non-HSV scar, vascularization, and more than 3 grafts came out to be significant. So I'd like to conclude with the following takeaways: that nearly 60% of optical penetrating keratoplasty performed are repeat grafts, so definitely need more studying, and 39% of them remain clear over a mean follow-up of 31 months. Half of these grafts fail post-rejection and 1/3 post-infections. And still, the practice pattern of immune modulation is limited to 7 to 20% of these patients. It needs to be studied further, and that is what I would like to recommend, that we need to have randomized controlled trials in this particular subset of OPK followed by OPK patients. And that is the strength of our study, that we did a focus subset analysis. Thank you.
So what is your learning from this? Like, what kind of practice protocol would you like to practice now that you've done this
Correct.
study?
So that was the entire point, that we wanted to study this subset away from the EK subset, because they tend to skew the data. So the learning that came from this particular paper is that we need immune modulation to be more robust, because the patients in whom immune modulation. So I did an analysis as to in patients in whom immune modulation was given versus patients in whom it wasn't given. I realized that that is another subset of this study, that patients who had baseline higher risk factors among already a high risk were the only ones where we gave immune modulation. So outcome of that may not be the correct way to analyze whether it works or it doesn't. So definitely an RCT is needed in this particular subset, where we can analyze with immune modulation versus without immune modulation. While there may be some ethical aspects to that as well. So this is something which needs to come up next. The second thing is, when the primary graft indications, age of patient, number of graft, when we know already that it's falling in that bracket where the chance of failure is going to be higher, it needs a more robust follow-up as well. So I think that was the second thing I learned.
And what about immunomodulation? By that, do you mean steroid or steroid sparing, or what?
Yeah, so in the preoperative period, since they are failed grafts, so they have been on topical steroids. For that reason, I excluded the topical steroids from the immune modulation, and I'm talking of steroid sparing agents only.
Thank you.
Thank you.
Thank you, Anubha.